Afternoon. Good morning and afternoon and evening, everyone, wherever you are in the world. My name is Serge Kremers, and my co-host is Peter Ferdinandi. I'm professor of pathology and medicine in Columbia University, and Professor Ferdinandi is at the Semmelweis University in Hungary. We'd like to welcome you for a very nice webinar that I'm really looking forward to. It illustrates the breadth and depth of pharmacology and clinical pharmacology and translational pharmacology that is being published in our flagship journals, British Journal of Pharmacology and the British Journal of Clinical Pharmacology. And so it ranges from preclinical, translational to clinical research, as well as from academia to industry. And we're very proud and looking forward to the speakers. And I will leave it up to Peter now to introduce our first speaker. We'll have, by the way, 4 speakers. Sorry, Peter. 4 speakers, each have about 15 to 20 minutes. After each speaker, there will be an opportunity to ask questions. Please ask your questions in the Q&A box, and we will handle them accordingly, according to the sequence that we get them, receive them. And then we move on all the way to the end. We'll probably reconvene, and hopefully there will still be many of you listening and looking forward to a lively discussion on the various subjects. So without further ado, Peter, please.
Yes, thank you very much. So we managed to select the most downloaded papers to show you, and we do hope that these papers will be the most cited ones as well. And we want to encourage all of you to submit your best pharmacology work to either British Journal of Pharmacology or British Journal of Clinical Pharmacology. It's my pleasure to introduce the first speaker, Professor Andreas Papapetropoulos, who is a director and a professor of the Department of Pharmacy at the University of Patras in Greece. And he's also acting as a senior editor for reviews and themed issues for British Journal of Pharmacology. And in fact, he will talk about a new series of reviews, what actually it was his idea to initiate. So in each year, we will summarize the new drugs approved by either EMA, FDA, or the British authorities, MHRA. And this is in this year we published the very first review. And Andreas, so I ask you to summarize your paper, and I think it gives you a new aspect of these new drugs. Thank you very much. Looking forward to your talk.
Well, let me start by thanking Peter for the kind introduction and invitation, and Serge to participate in today's webinar. And to be honest, I felt a little bit awkward being asked to present a review paper. The rest of the speakers in the webinar are presenting original research, but still, I think what we're trying to do with this review, and it's going to be eventually a review series, as Peter said in his introduction, where we do this every year, we are trying to summarize all the new drugs that are approved in Europe, represented by the EMA and the MHRA, and in the United States, approved by the FDA. And hopefully, as we go further along, we'll be able to incorporate additional countries like Australia or maybe Japan and China, although there are difficulties with some of these regulatory agencies, such as public information and how to retrieve it. So as Peter said, this is a mini review that was published for the first time this year. We published it in late January We would like to be able to do that a bit earlier in the month to compete with Nature Review's drug discovery that does a similar review, which is only focused on drugs approved by the FDA. And it has been co-authored by the entire senior editorial board of the British Journal of Pharmacology, with the addition of Dr. Nayer Coyle, who helped us with the MHRA, drugs approved by the MHRA, and Professor Topouzis, who did the majority of the work for the first draft of the paper, which we then edited and improved. So Peter already said that this was this proposal that was made during an editorial board meeting, I believe, in Liverpool a couple of years ago, and it was later decided by the senior editorial board at one of the meetings that we should go ahead and publish this review. And as I said already, there is one that we probably, many of us, if not all of us, refer to annually, which is published in Nature Reviews Drug Discovery, which only includes drugs approved by the FDA. And the other problem we saw with this is that it's more like a news piece, excuse me, rather than a review, meaning it has tables with the drugs, it has some graphics, but it does not have any references. So we wanted to collect all the information from the three major regulatory agencies, EMA, MHRA, and the FDA, and put together a review that includes all of the drugs approved in the previous year. And we mainly targeted, obviously, pharmacologists everywhere in the world, healthcare professionals, physicians, researchers, and teaching staff, for where we would enable the versatile use of information in this review, and would have tables and easily clickable information that would take you to the relevant PubMed publication where you could get the original information from. And we wanted to place an emphasis on pharmacological innovation and novelty, and we wanted to focus and have a big part of the review describe the first-in-class drugs. So these were the overall aims for writing this review. And what we were surprised when we started out, I thought it was gonna be a pretty straightforward approach, meaning we get the lists from the three agencies and then eliminate duplicates and just list them, describe them, and make some graphics. Well, the first problem we ran into is drugs are not simultaneously approved by the three agencies. So something that was approved in 2022 by the FDA might be approved in 2023 in one of the other two agencies. So that would mean that we would have the same drug in 2 consecutive years, which is not what we wanted. So we set arbitrarily this rule that in order to be included in our review, the drug must be a new molecular entity or biological product having never before received marketing approval by any of the three agencies, and thus enters the first time the market in either Europe or the United States. And if the product is a combination, it is either a novel combination of already approved drugs, or at least one of the active ingredients is a novel compound that is approved for the very first time. These 4 constitute the exclusion criteria. The molecule would be excluded if it's a new formulation of an already approved medicine. It would be excluded if it received authorization in 2023 for use in a new indication, whether the same general field or different field, or if it's a generic or biosimilar version of previously approved drugs, or if it is an updated version of an already approved vaccine. When we implemented this criteria, we ended up with 70 drugs that we divided into 4 different categories. Small molecules and peptides, there were 37 drugs in this category. Proteins and antibodies, 16 drugs in this category. Advanced therapy medicinal products and RNA-related products, 11 entries in this category, and then we had 6 vaccines. One of our goals was to present the information in tables that are easy to use for people in their class presentations, seminars, and also establish sort of a trademark look for the information presented. So just like when you see something from Cell or from Nature Reviews series, you know which journal it is coming from. We thought we'd come up with a unique style, and this is what you're looking at, and I'll take the blame for the choice of colors and everything else. Maybe not everybody would agree with the aesthetics of what is presented, but the goal is to have something that is identifiable. Just by looking at it, you know that this comes from the British Journal of Pharmacology, and the professional artists that work with Wiley helped us a bit with putting these together. So with these, here you can see all the individual drugs. Of course, I'm not going to go into each one of them, but what I'd like to highlight is that for each of the category, we not only presented a figure like this that can be used as a slide, but we also made tables for each of the 4 categories. So we had 4 tables in the review, and the information that's contained in there is as follows. It has the active ingredients and proprietary name of the compound. It has the approved therapeutic use, the disease against which it's approved, or the condition that is targeted, the molecular target and the mode of action, whether it's a receptor, an enzyme, a transporter, if it's an agonist, an antagonist, what exactly it is that it does to exert its action. And we also list the approving agency and also the approval type. So we list whether it's a priority or a breakthrough or an accelerated approval or a fast track approval. And every agency has its own rules. You can see them here on the right-hand side in this box, and you can look it up if you want in the review. And I get more information. I won't analyze what each agency considers expedited approval. But be that as it may, expedited approvals denote that there is a special medical need, the breakthrough nature of the drug that's being approved, or that it uses reliable surrogate endpoints that's useful for other trials. So in addition to the agency, we list the approval type, and we also provide a link, a clickable link that takes you to the pivotal clinical trial that led to the approval of this product. And then we highlight the first in class, and to do that, we use a different color in the table. So here's an example of the table. And here's the different columns of the table. Active ingredient, you can see the drugs are in blue. The reason for that is they're clickable. If you click on there, you'll be transferred to the Guide to Pharmacology by the IUPHR and the BPS that's published yearly. So by clicking here, you're transferred there. There's also the proprietary name. The approved therapeutic use, you can see here what exactly the indication is. We didn't use a single word like anemia here, but we used the full indication for which it was approved. Anemia caused by chronic kidney disease for adults on dialysis for at least 4 months. So a full approval. And here again is the molecular target that's clickable and refers you to the Guide to Pharmacology, the approving agency. Some of them are approved by one agency, some others are approved by more than one. We noted that most drugs are approved by the FDA first before the EMA. There are several reasons for that, but we have a short discussion in the article why, the mini review, why that might be. And the approval type, and here at the very end is the pivotal clinical trial, which is not in the reference list. We try to keep the references to a minimum, and these are clickable that take you to PubMed, and you can look up the entire reference. Now, the graphics we used, in addition to what we had them before as chemical categories, here drugs are divided in a different way, approvals by disease area. Most of them were in oncology. an equal number for inflammation, blood, and infectious diseases, blood meaning anemia, sickle cell disease, hemophilia, this type of indications. And then there were others, fewer for a kidney, metabolic, and endocrine, some for neurological indications, and whatever did not fall into these categories was classified as other. I will give an example of two more useful boxes, tables that we've generated for this review. Here we have collected all the first-in-class compounds. There's 70 out of the total, there's 30 out of the total 70 approved that are considered first-in-class. And some of them here are, I'll just mention a few examples. It's beyond the point of presenting each individual drug during this webinar. There's two, these two are respiratory syncytial virus vaccines. There's two different treatments for sickle cell. This Exacel has a longer name, but it gets confusing to pronounce. And this other one, and the difference between these two is as follows. Both use hematopoietic stem cells. In one case, the hematopoietic stem cells, autologous, removed from the patient, are transformed with CRISPR-Cas technology so that they express fetal hemoglobin. Or in a more classical approach, the hematopoietic stem cells are infected with a lentiviral vector that produces a soluble form of beta globin that has anti-sickling effects, so it corrects the shape of the erythrocytes in sickle cell disease. One more notable example is down here, lecanemab, which has been shown to slow cognitive decline in Alzheimer's disease. And the reason why it does that, it has a different profile of binding amyloid, beta amyloid. It binds the aggregates that are soluble rather than the monomers or the amyloids that is in plaques. And another noteworthy example is this sparsentan, which is a compound that has a dual mechanism of action. It has two pharmacophore structures, one that inhibits the endothelin receptor A type, and one that's based on irbesartan that blocks the angiotensin 2 type 1 receptors, and it was approved as an antagonist for these two receptors for proteinuria in IgA nephropathy. One more example that one could mention from this table is this vadadustat and its closely related compound daprodustat. This is approved by the FDA. This is approved by the EMA. And it's a prolyl hydroxylase inhibitor that's orally available for symptomatic anemia caused by chronic kidney disease in people under dialysis. Previously, there were no orally available drugs. Patients had to rely on injectables like erythropoietin and darbepoetin. But unfortunately, these compounds, these small molecules, do have similar side effects in terms of thrombosis, and they have received warnings, a black box warning for the FDA, and also a warning in the packaging leaflet for the EMA. If I can show you this, another example of how we highlighted drugs that we felt are important here, and drugs that are used in orphan diseases. They're not first in class. Some of them are me too, so to speak, drugs. And of course, I would like to remind everybody that orphan disease definition is not the same everywhere. It's 1 in 2,000 in Europe, and it's 1 in 2,500 for the United States. And one gene therapy product here, that's an HSV1 delivered collagen in dystrophic epidermolysis bullosa, which has for patients with a mutation in the collagen 7 alpha 1 gene. Also an tofersen, which is an antisense oligonucleotide that targets mutant SOD in ALS, and zilucoplan, which is a synthetic peptide that blocks the activated form of complement 5A and 5B from complement 5. This year, 2 more agents were approved that block C5, and one is an aptamer, RNA aptamer, and another one is a monoclonal antibody. There have been drugs, there has been already on the market one drug that blocks complement 5 on the, so these are not first in class. So in summary, 70 new medicines were approved in 2023. Almost half of them are first in class. And this is shows the innovation and inventiveness in the drug discovery approval field. There's a significant number of them that target rare genetic diseases or intractable diseases. And there's also equally important to note that there are some neglected areas, such as there are no drugs for cardiovascular disease or pain. Of course, I guess anything that's in the blood could be classified under the cardiovascular disease. I don't know if anemia would qualify under this title, but there are no drugs for certain areas. I guess this shows the priorities of the pharma industry. There's a continued emphasis on polypeptides, proteins, antibodies, advanced therapy, medicinal products, and RNA therapeutics. And we had, if we were to highlight 2 of the most important discoveries of last year, I would personally pick the CRISPR-Cas9 first drug that uses this technology to treat sickle cell anemia and beta thalassemia by the MHRA. So this drug has 2 indications in the for MHRA, but only 1 for the other agencies, and also the breakthrough therapy for slowing cognitive decline in Alzheimer's disease. Before ending, at the time I hope, I'd like to say that this article has been downloaded or fully viewed 6,500 times since it was published in February. It's the most downloaded paper, but unfortunately, it has only received 1 citation so far. If you think the information there is useful, please cite this article in reviews or papers you write. I'd like to stop here and thank you for your attention, and take any questions now or later as the chairman decide.
Yeah, thank you very much. We have 2 minutes for questions. So far, I don't see any questions from the audience at the Q&A box, but Serge, please.
Yes, I have a question. I mean, this must have been quite a tour de force to put together, and it's really interesting to see. What I've always wondered, and perhaps you can tell us a bit about that, is whether there are drugs that have been approved by one agency but not approved by another, and not because they haven't gotten around to it yet, but because they simply did not approve the application. Are you aware of any of those? And how did
I know there are. I'm going to stress my brain cells, and if I don't come up with anything, I'll look it up over the break and answer to you. I'm sure there are. I'm trying to remember which. There are a couple of very well-known examples that the safety profile was unacceptable by the EMA. I have the feeling that the EMA is more conservative. Many times it's slower and perhaps more conservative. I'll look it up and come up with names. I know there are.
Yeah, and I saw one interesting point is that the anti-amyloid antibody was showing effectiveness, because this amyloid his story was much criticized in the literature on Alzheimer's. So, but I think that since this drug is approved, I think it's a pure proof that the amyloid story is really, true. What do you think about it?
Well, in theory, there was the first antibody that was approved. I think it's already withdrawn from the market due to lack of efficacy. And this bound only amyloid in plaques. So this was shown not to be effective in slowing the progress of slowing down the progress of the disease. This new monoclonal antibody has a different profile, as I said before, in targeting different pools of amyloid, whether the one that's aggregated but soluble, not yet incorporated in the plaques, and apparently for reasons that I don't know if they are unknown or just I don't know them. It's this selectivity profile gives it an advantageous characteristics, and it shows this slow progression.
Thank you very much. Yeah. Thank you very much, and thank you for leading to put together this really huge work. And I hope that sooner or later it will be well cited. And since it's the first paper of a series, we will repeat it next year as well. So thank you very much, Andreas. And may I introduce the next speaker, Gautam Gampa. Can you please switch on your camera? And thank you very much. And this is this is an original paper what Gautam will present. He is from Genentech, South San Francisco, California. So this is a good example of an industry paper. You know, BJP is very welcome for all industry papers as well. So the floor is yours.
Thank you for the kind introduction. Hopefully my slides are coming through.
Yes, perfect. Thank you.
Yeah, thank you so much for this kind opportunity to present at this webinar. We have recently published our findings on the anti-CCR8 antibody, essentially focusing on the preclinical and the translational story in the British Journal of Pharmacology. So I'm pretty excited to sort of again present a summary of our research work here at this forum. Before I get into the crux of the story, I wanted to take a moment to acknowledge the key contributors, particularly the co-authors on this publication who have contributed directly to the results that I'm going to be sharing today. Additionally, the project team members who have been involved with these programs, and also the PTPK group, or the preclinical and translational PK/PD group at Genentech, which I am directly part of, and the broader organization, which is essentially the Genentech Research and Early Development. So as it has been broadly recognized in the field, regulatory Tregs are a major immunosuppressive cell type in the tumors and can suppress both priming in the lymph nodes as well as the effector T cells in and around the tumor. And in clinical analysis, it has been shown that the presence of Tregs is associated with poor clinical outcomes in cancer patients. Given this, depletion of Tregs, as in the therapeutic depletion of Tregs, represent a promising approach to reverse immunosuppression and thereby restore anti-tumor immunity. And this is something that was very appealing to us. And so we pursued sort of the development of an antibody against a specific target that can deplete the subset of Tregs in the tumor microenvironment. While we were looking at several targets that are expressed in Tregs, we came across this target called CCR8, or the CC-motif chemokine receptor 8, which has been identified as a selective marker for Treg cells in the tumor. As can be seen from the bulk RNA-seq data on the top here, it is broadly expressed in multiple solid tumor types, and also it is significantly upregulated in multiple solid tumor types compared to the relevant normal tissue. And given this, this has been sort of selected as a suitable target. And the other interesting thing, as can be seen from the bottom, it is highly upregulated in Tregs in the tumor with minimal expression in other cell types, such as the conventional CD4, as well as the effector CD8 population, as well as if you look at the PBMCs, the expression is much lower or minimal in all these subset of cells. Given this, CCR8 was selected as a promising target to sort of preferentially deplete Tregs in the tumor, and thereby it has a promise with regards to enhancing anti-tumor immunity. So with regard to the antibody, the anti-CCR8 antibody or our lead candidate is a humanized IgG antibody, which was produced in CHO cells, and the Fc region is afucosylated to improve ADCC activity. It has a low picomolar binding affinity to cyno and human, so essentially it cross-reacts with cyno and human, but it does not cross-react with mouse. Given this, we also developed a surrogate anti-murin CCR8, which was again used to establish proof of concept in mouse tumor models. The backbone for this is the murin IgG2A, and it's again produced in CHO cells. We have shown that it has a low picomolar binding affinity as well, and it only binds to the mouse target. So essentially, we use the murine surrogate antibody to establish POC in mouse studies and use the lead candidate to show that it is active in vitro assays, as well as we did some cyno studies to characterize the antibody further before we took this antibody into the clinic. And today I'll be sort of essentially summarizing some of the results with both these molecules. The murine anti-CCR8 antibody showed a potent activity in the murine EO771 mouse tumor model. As can be seen from these plots, we see selective depletion of Treg cells in the tumor, but not in the blood. And the depletion occurred in a dose-dependent manner following single dose of this antibody. Additionally, exposure was confirmed in the study across the dose levels. There was a slight trend of greater than dose proportional increase in exposure in the mouse studies. Additionally, we also looked at the efficacy in this tumor model, and we saw dose-dependent tumor growth inhibition in the EO771 model. We also did some combination efficacy studies with PD-L1, and there was some synergy when we co-dosed them together. Again, the data shown here is only showing the single agent activity. Just given it's a short talk, I tried to pick some key data sets, but the other data is presented in the paper if anyone is interested in going through it. Additionally, we also looked at a couple of other models like the HEPA-1/6 hepatoma model and showed we see similar activity in those syngeneic mouse models as well, demonstrating broad activity across more than one model. Moving on to the lead candidate, we showed that the lead candidate has robust ADCC activity in vitro assays shown on the right side here. So we looked at dissociated tumor cells from renal cell carcinoma, and within these cells, the afucosylated lead, which is shown by the red line, demonstrated robust activity, and the activity was improved compared to the fucosylated control shown in blue. We saw a similar phenomenon with regard to the activity in pre-activated PBMCs, which were pre-activated to induce expression of CCR8 on Treg cells from PBMCs. And we do see a similar depletion of Treg cells with our lead candidate. And in both these studies, we did not see depletion of the conventional CD4 or the effectors CD8 population. This was exciting as we sort of moved to perform some in vivo cyno studies with this molecule. We also confirmed that the binding to Fc gamma 3A was improved with the afucosylated lead compared to trastuzumab, which had a wild type Fc. Moving on to the cyno studies, our lead candidate shows typical bi-exponential behavior in the cyno studies following single dose administration of 10 milligram per kilogram. And the profile was very similar to anti-GD, which we use as a typical control in these studies. Anti-drug antibodies appeared in 1 out of 3 animals in these studies. However, the systemic exposure was maintained through the duration of the study, which is 35 days. We also looked at PD following single dose of anti-CCR8 in the study, and we see decreased frequency of CCR8 expressing Treg cells. We did not see any clear reduction of the total Treg cells, and the reduction of CCR8 specific Treg cells was sustained through the duration of study. We also evaluated the cytokine release, or like if there is any increase in cytokine secretion following anti-CCR8 treatment. And we only saw minimal cytokine secretion as shown by the profiles for both MCP1 and IL-6 here. When compared to the control, we saw only minimal and transient modulation of these cytokines. We additionally looked at the in vitro cytokine release assay, wherein we did not see any significant increases in cytokine secretion from PBMCs compared to the vehicle control in a soluble assay format. And overall, these results suggest no major risk of excessive cytokine release in patients in the clinic. Additionally, with regard to the safety findings, we did not observe any key safety findings that were attributed to the treatment. So overall, this molecule was well tolerated in the single dose study, and then we sort of went on to do a repeat dose study in cynos to further sort of confirm this and also understand a little more with regard to the safety of this molecule over a longer duration of time. Consistent with our findings from the single dose study, we saw a dose proportional exposures at the tested dose level in the typical IgG-like antibody PK. We saw some accumulation of exposure on repeat dosing. In this repeat dose study, we saw incidence of ADAs in roughly around 50% of animals. However, it was not associated with any impact on systemic exposure, and exposure was maintained through the duration of the study, which was greater than 7 weeks. And with regard to the PD, we saw a reduction in the CCR8 positive Treg cells at both the dose levels tested, which is 30 milligram per kilogram and 100 milligram per kilogram. The earliest time point we looked at in the study was 3 days, and we do see reduction at that 3-day time point, which is again sustained till the end of the study, which is 45 days. We did not see any effects on the total immune cell populations, and we also did not see any changes in the total Treg cell counts, which is again consistent with what we saw from the single dose study. With regard to safety, the treatment with anti-CCR8 at both dose levels was well tolerated without any treatment-induced in-life findings. And given this, the no AEL or the no observed adverse effect level was identified or established as 100 milligram per kilogram. We then used a minimal PBPK-PD model that is essentially shown here in the schematic, which includes the key compartments with the presence of target. And the antibody is dosed into the central compartment via IV dosing and can distribute to each of these compartments and recirculates through lymph back into the blood. Upon binding to CCR8, it is able to deplete Treg cells and drive increases in CD8 positive T cells, which results in killing of tumor cells. The key inputs and model outputs are sort of stated on the left, but in the interest of time, I'll keep moving to the next sort of slide. So the model was able to capture the dose-dependent mouse PK, PD, which is the Treg counts, as well as the CD8 positive T cell increases, as well as capture the tumor growth inhibition profiles. Additionally, we also calibrated the model to PK at the 10 milligram per kilogram single dose data, and also validated it against the 30 and 100 milligram per kilogram cyno data following the repeat dose administration in cynos. We then used the PK and scaled it to human to allow us to sort of simulate the clinical PK profiles. Essentially, this clinical PK and receptor occupancy profiles are shown in the plots here. The top panel shows the peripheral simulations for PK and RO, and the bottom panel shows the tumor simulations for PK and RO at various dose levels, all the way from 0.2 to 20 milligram. And overall, we expect a linear PK in the clinic for our antibody. And as clinical data becomes available, we'll further use that data, essentially use the model to capture that data and further refine our estimates and inform future dosing decisions. With regard to the selection of the first in-human dose, we have used an integrated approach. The proposed starting dose of 2 milligram was based on this integrated approach using the totality of clinical data, and was guided by insights from our modeling analysis. As stated, discussed in the prior slides, anti-CCR8 did not induce significant release of cytokines in the in vitro human PBMC assays, even up to a high concentration of 1500 microgram per ml, providing high safety margins. Additionally, in the cyno studies, it was well tolerated, again providing safety margins of around 3000-fold when we compared the starting dose of 2 milligram to the NOAEL of 100 milligram per kilogram. Additionally, we saw minimal cytokine release, suggesting low risk for any CRS events in the clinic. Additionally, the model was used to predict the average receptor occupancy over the first dosing interval in the tumor, and it was roughly around 80% at the first in-human dose of 2 milligram. And this served as an anchor point for the selection of starting dose, and it is again shown in the plot on the right in the blue bar. Moreover, we have some clinical experience with other Treg targeting afucosylated molecules that have been safely administered in the clinic, which provide additional confidence with regard to the safety profile of this molecule. And overall, these pieces of data justify the selection of 2 milligram as a starting dose. We considered other approaches, but we did not feel that they were appropriate due to certain limitations. If you look at the plot on the right, the MABEL and the MPAD, or the minimum pharmacologically active dose, which are traditionally used for starting dose selection, would result in a much lower starting dose of less than 100 microgram, given the superior preclinical safety profile, and that the target is predominantly expressed on a small and unique population of Treg cells in the tumor with minimal off-tumor expression. We feel that a conservative MABEL approach is not necessary. And given these rationale, we went ahead with a proposal of 2 milligram starting dose for the phase 1 clinical study. In the interest of time, I had one more slide just summarizing the results, but I think I'll just skip sort of going through the slide and see if there are any questions.
Thank you very much. So the audience is requested to take questions on the Q&A box, but I don't see questions here. We still have 3 more minutes. So this was a very nice example of an industrial development of a novel class of antibodies on a new target. It was really interesting. What do you see? What could be the major risk of potential safety issue in the patients with this new target? So if maybe the depletion of the CCR8 positive Treg cells, so is it a risk to develop maybe some other immune related diseases? Or so what would you think of this? I think that it's very safe so far, but the risk is always there. Yeah.
Yes, again, based on the preclinical profile that we have seen for this molecule, it seems to be very safe, and we don't expect any major safety issues in the clinic. But again, theoretically, it could have a slight risk of autoimmune kind of diseases. But again, the expression of CCR8 in the normal tissues such as skin is much lower, and also the expression levels on Tregs is much lower, though there is some expression. So that is the only slight risk that we see from the safety point of view. But other than that, we don't expect any major risk. And even that risk is low given the target expression profile is much lower compared to what we have in the tumor.
Thank you very much. We run out of time, so I pass on the floor to Serge. Thank you very much. And if you have some questions at the end, you can come back. Okay, thank you.
Well, thank you, because I did have a question for him, but we'll move on to the next speaker then, Gautam. I'll save it for the rest of the talk. Oh, thank you. And so from San Francisco, we go to Finland to Dr. Henrika Hakomäki, if I pronounce that correctly, from the University from Eastern Finland in Kuopio. I practice. And
nice job.
You're welcome. Who also is who published one of the papers, or was a co-author of one of the first authors of this paper on oxycodone in breast milk. And it has been downloaded many times. As a matter of fact, I've never seen anything like it, although now it sounds like Trump. So I hope I didn't. But I hope this is a great paper. It's obviously a very important subject that speaks to the mind of many people. So Henrika, I hope you can tell us a little bit more. Thank you.
Yeah, thank you so much, Serge, and thank you for inviting me to talk on this webinar. I will just share you my slides first. Okay, are you seeing my slides okay?
Yeah, all looks good.
Perfect.
Great, thank you. So my talk is about oxycodone excretion into breast milk. And first, I would like to acknowledge this study was done in the University of Eastern Finland, and Kuopio University Hospital is where the clinical study was conducted. This got funding from the Finnish Cultural Foundation, which we are very grateful for. Atmoscope is a company that did the analytical method and quantified our samples. We are very grateful for that as well. And here you can see the article, which is called Breast Milk Oxycodone Concentrations in Mothers Given Oxycodone for Post-Cesarean Delivery Pain Management. And first of all, effective analgesia and early breastfeeding initiation are crucial for both maternal and neonatal well-being after cesarean delivery. And we know that the first days after delivery are very crucial for the whole breastfeeding journey, and inadequate pain management after cesarean delivery may negatively impact this. And this is why it is very important to investigate what drugs can be considered safe for this population, meaning the mother and the infant, to effectively treat the mother and avoid any toxicity that could be seen in the infant. And oxycodone gets a little, I would say, a bad rep, but oxycodone has been demonstrated previously by Mäkelä and colleagues to have efficacy in postoperative pain management following cesarean delivery as part of this multimodal analgesia, which I will talk a bit later more about. Oxycodone is a semi-synthetic opioid and is used in moderate to severe pain. And in Finnish hospitals, we use it as part of multimodal analgesia in cesarean delivery when needed. And it is recognized earlier that oxycodone is excreted into breast milk and can cause adverse effects in infants, and therefore large doses are of course not recommended. And there are differences in current practices and guidelines for the use of oxycodone during breastfeeding, and these are something I picked up from the internet. And the first one is from LACTMED, which is an NIH database. They have also referenced our article in there, and they say that daily doses less than 60 milligrams of the immediate release formulations are likely to result in clinically relevant exposures in the neonate, and they do not recommend extended release oxycodone products. I am assuming it is due to the low amount of studies that have been done on the subject. And they say also that the maximum oxycodone dosage of 30 milligrams daily is suggested. And it is pretty much the same story in the Finnish national database, so that daily doses over 30 milligrams are not recommended. So we did the study because the limited knowledge is available on oxycodone transfer into breast milk and the consequent neonatal exposure. Previously, Seaton and colleagues found that oxycodone was excreted into human breast milk, and the study setting was pretty similar to ours, so it was post-cesarean. And our aim was to, first of all, pretty much replicate what Seaton et al. Had been doing to determine the oxycodone excretion, but we also wanted to measure its metabolites because we know that it has active metabolites, for example, oxymorphone. And with this information and with the previous studies that we have done on oxycodone, we wanted to estimate the neonatal exposure. We also had a secondary aim to compare the analgesic efficacy of the controlled release oxycodone naloxone and the controlled release oxycodone treatment. But I am not going to focus on that aspect of the study in this presentation, as I have a limited amount of time, but I'm just going to say they were found equal, which is unsurprising as they are designed to be equal in their efficacy to control pain. Our study design was randomized, double-blinded parallel group study in parturients coming for elective cesarean delivery, and we had 43 patients with normal full-term pregnancies, no twins in this study. Surgery was done under general spinal anesthesia in Kuopio University Hospital. I think we use fentanyl and bupivacaine. And we use this multimodal post-operative pain management, which is talked about in here. So we randomized our patients into two groups receiving oxycodone, the investigational oxycodone twice daily for the first 3 post-operative days after the surgery. And the first one was the oxycodone naloxone group, and the second one, the oxycodone group. And we gave this as part of the multimodal pain management regime. In there, we also gave non-steroidal anti-inflammatory ketoprofen and paracetamol. And in addition, the patients were allowed to have at need oxycodone if they wanted to. And that data is also shown later. We sampled the mother. We didn't sample the neonate. This was not in our ethical license, nor did we want to do that actually, because it's difficult enough to get patients. And if you want to take blood from their newborn infants, it's even harder. So we took plasma and milk from the mothers, and the interval basically between the plasma and milk was something not more than 3 hours, I would say. Everything more than that, we excluded from the data for the analysis because we wanted to have them at the same time, but it wasn't possible all the time. And so LC-MS measurements, we did quantitative analysis on oxycodone, noroxycodone, oxymorphone, and noroxymorphone, which are the metabolites of oxycodone. And in addition, we collected basic demographic data from the mothers and the neonates, so APGAR scores and basic information. The maternal pain intensities were also recorded, but as said, I'm not going to go very much into detail on those. And then using PK simulations, we estimated the neonatal exposure. And previously, our group has determined the pharmacokinetics of oxycodone in pediatric patients, and we used this knowledge to our advantage to assess the neonatal exposure. And yeah, as said, we did this using the pharmacokinetic simulations, and we did it for a hypothetical neonate receiving oxycodone through breast milk. And we did it in so that we did 5 different scenarios. And the first one represented the normal situation. So the mothers and the neonates that we had in our study. And then we tweak the parameters to be biologically relevant still, but to estimate the highest possible exposure that could happen. And I'm not going to go into detail on these, but here are just what we did the equation-wise. So we estimated the parameters of AUC, plasma steady-state concentration and plasma maximal concentration, and calculated the relative infant dose, which is often used to say or assess if a drug is safe for a neonate, and commonly RID of 5 to 10% from the literature is considered rather safe. And moving on to the results. So here you can see a table of the oxycodone consumption during the first post-operative days. And as you can see, many received rescue oxycodone during the first post-op days. So the results, especially from these days, are not a perfect representation of the extended release tablet pharmacokinetics. And here you can see all of the concentrations that we quantified. And as you can see, there are no major differences between the groups, and this is what we expected to have. And unfortunately, we were unable to quantify oxymorphone and noroxymorphone from the breast milk samples, as we had some sort of ionization issue, which is probably due to a matrix effect in human milk that hindered our quantification, and the results were seen unreliable. So we did not, unfortunately, have those results, but we do have them from the plasma. And here you can see from the breast milk, the oxycodone highest concentration that we saw was around 100 nanograms per milliliter. This is relevant because we did use that in our simulations. And here you can see the oxycodone concentrations and in breast milk and maternal plasma. And as you can see, the concentrations in breast milk are higher than the plasma. and we calculated the milk to maternal plasma ratio to be around 3.2. And for noroxicodone, pretty similar story. Breast milk concentrations again are higher, and the milk to maternal plasma ratio is around 3. In addition, the noroxicodone concentrations did exceed oxycodone concentrations in milk and plasma, and their ratio was 2.3 in milk. Here is a table for the simulations. And as you can see, we did have the 5 scenarios, and 1 represents the average exposure. And so, yeah, we did the simulations towards the most drastic situation for a 3.5 kilogram neonate receiving oxycodone through breast milk at post-op day 3. And here you can see that, for example, V milk, so the volume of milk, we did increase the consumption, and we decreased the clearance, increased the concentration of oxycodone in milk, and so forth. And here you can see that the highest possible concentration with the simulations was 5.4 nanograms per milliliter. So in the worst case neonatal exposure, we had the 5.4 nanograms per milliliter, and to put this in context, the proposed theoretical plasma concentration that would for infants would vary between 12 and 35. So it can be assumed that the 5.4 may elicit some opioid effects, but it is unlikely to be toxic. And in our worst case simulation, oxycodone dose received from breast milk was around 0.009 milligrams per kilogram per day, which is very much lower than the therapeutic IV dose of 0.39 used in term neonates. And yeah, just to point out that ours is through oral ingestion and this is IV. So yeah, and so the estimated rate was less than 10 in our worst case neonatal exposure. And here's the same pretty much for the typical neonatal exposure in our study population. And the Cmax for the neonates was only 0.15. And we did estimate the rate for all of the mother neonate pairs, and it was below 1% in all individuals. So I think I already said this before, but we did have challenges, and there are limitations, of course, in every study. But we were unable to collect all the breast milk samples simultaneously with the plasma samples because there was a delay in, for example, injection of the breast milk, and some of the participants were unable to provide any milk samples during the study. But yeah, these are real people, so this happens. And also the neonate plasma was not collected in the present study, and thus we did not have data on newborn exposure, only the estimates. Of course, one limitation is also that we were unable to measure the oxymorphone, which is the most potent of the metabolites. So we found out that oxycodone and noroxicodone are excreted in small quantities into breast milk, and noroxicodone concentrations are higher in milk than plasma, and maternal plasma concentrations of noroxicodone exceed oxycodone. Noroxicodone has a higher half-life, a longer half-life, so it makes sense in here. And we suppose that the clinical relevance of this finding is likely minor, as noroxicodone only has a weak activity on the mu-opioid receptor. Yeah, the oxycodone dose received from breast milk during the first 3 post-operative days is assumed safe for healthy and term neonates with the current regimen we have used in this study, and only in extreme cases would we assume it to be possible for the neonate to receive a dose that may elicit opioid effects. And here I must acknowledge that I am affiliated with University of Eastern Finland and all these nice projects that we have. Yeah, thank you.
Thank you, Henrika. That was wonderful. I'm looking into the Q&A and I see a question. It is, are there any long-term risks with postnatal oxycodone use, or is this mitigated by the short use time?
Yeah, so we only use it for 3 days in the current study, and not even that. Not all the mothers used oxycodone for 3 days, so many of them ended it when there was no need for it. So I would say that in the regimen that we have used, it's very likely that the 3 days is all they would need, and I would say that long-term risks for the neonate are to be very, very low. But yeah, we didn't study this, so I can't be certain.
Thank you. All right, Peter, yes.
I have just a quick comment that you mentioned that you couldn't be able to measure the metabolite oxymorphone. And it's expected a little bit. Once we did a breast milk study as well, and it was very difficult to select the company service provider who could measure some compounds from the breast milk, because there is a matrix effect for sure. So maybe
Yeah,
it's
good.
good to develop the method beforehand. The study, because it's not obvious to measure. Yeah, and there is also a difference in colostrum and breast milk as well. So
yeah, for sure, and it's kind of nice to hear that the others have had the same problem as well. Yeah, we didn't really expect this. The company that we did this with has provided their services for us for many occasions with oxycodone studies that we have done previously, and they have been wonderful. But I think we surprised them with our milk samples, so they didn't have the time to prepare, I would say. So yeah, some optimization really is needed, and it would really be good to have the method ready for future studies.
Yeah. Okay, thank you.
Thank you.
So thank you, Annika. I have some more questions too, but maybe we can discuss that later. So
yeah.
Moving on from from Finland to, I was going to say San Francisco, but I know you're in Glasgow, Marion. So Professor Marion Benny, University of Strathclyde in Glasgow in Scotland, and a lot of other colleagues that are involved in the paper on prescribing multiple drugs or polypharmacy in older Europeans. And this is very interesting, because this is ultimately what it comes down to, that when we're prescribing drugs, and we're prescribing usually not just one, but a couple of them, and we're very easily up to 7 or 10, but they differ from region to region and from within classes. I've been reading from her paper, but maybe you can inform us better yourself. Thank you, Mary.
So thank you very much, Serge, for the opportunity to speak today. I'm just going to share my screen, hoping this will work. I'll just pop it on to... Okay, so can I just check from somebody?
Yes, it all looks good.
That looks good. Okay, super. Thank you, Bonnie. So again, thank you for the opportunity. This was a piece of collaborative work across Europe, and with our industry partner, IQVIA, that we were able to undertake this study. So just the European group that I am part of is called the European Drug Utilisation Research Group. Started, been around for a long time, starting back in Hungary, and actually have been working really in this space for some time as a kind of specialist interest group within our host organisation, ISPE. So that's just to orientate you about the partners that have been engaged in this piece of work. And why polypharmacy? So in our context, and as I've said, Serge, with an ageing population and increasing use of increasing comorbidity drives really polytherapy, and also therefore the consequences of potentially prescribing medicines that have potential harmful impact as we move through the ageing process. So the community interested in drug utilisation is really interested in how do we, first of all, quantify this and start to describe this across different nations in a useful and helpful manner. So that was the context of why we started with this area of polypharmacy. And the challenges with that really are illustrated on this slide, that when you look at the literature, and we made reference to this in the paper, there is quite a lot of variation around the populations, and therefore when you start to quote prevalence of a condition, it's highly dependent on the heterogeneity of the population. It's also highly dependent on the actual data that you're collecting, and also the care processes that are happening within those individual environments. And as we were looking cross-nationally, then there's huge variation, not just in the service, but where that service is provided from, and therefore the challenges of data being able to look at that as a whole system at the moment. And then the third area is the methodological challenges. So we were sitting as a European group trying to think about what could we reduce variation in order to try and do a little bit more work around cross-national indication of the prevalence of polypharmacy and a little bit further investigation within that. So the aim of the study was to look at the prevalence of polypharmacy in older people. We defined them as over 65 across 6 separate European countries, trying to standardise the population cohort and the methods. And within that, to look at potentially inappropriate medicines, we've called them PIMS, in that population in the context of that polypharmacy cohort. And we were fortunate to work with our partners, IQVIA, who sit international data community, who sit with a richness of data. And we, partly the community of Eurodrug wanted to work with this data and get familiar with the data and the strengths and weaknesses of that data. So that's what was driving us analytically from a pharmacoepi perspective. So this slide just details specifically what we were trying to do with the study, and also the databases that we were using. We also had Spain. I don't know why it's been missed off this slide. We also had Spain. So there were 6 areas we were using that capability given to us through the IQVIA databases. And the data sources are across each of these countries. They are being provisioned at a primary care level, and the databases are trying to be consistently representative both of the primary care physician population and also of the representation of the actual populations within those different countries. So that's the asset that we were working with analytically, and then also the different types of tools and platforms that we used within the IQVIA capability to undertake that. And it was postdoc researchers within our Eurodrug community who were actually working alongside our IQVIA analytical staff to generate the data that was delivered. Just another slide around the capability of the platform. I'm not going to go through it because I'm not technically so knowledgeable, and it was the team that was actually working with us. But you can see from that where the focus was what the cohort was, what kind of data assets that we were working with in this IQVIA 360 platform. But more interesting to the actual cohort, what were we trying to look at? So we were looking across 6 countries. We were looking at a population over 65 years and in a window of exclusion in 2018. So they must have had within their general practice setting within these countries, over 2 recorded visits in that period. And then from that, we then worked out what was the inclusion assessment window and the covariance, both for comorbidity. So we looked back from that index date for 12 months, and for prescribing, we looked at a 6-month window. We looked at all medicines apart, but we had definition that was standard, so we didn't look at what were potentially considered short-term items such as antibiotics. We list this all in the paper, or irregularly, so quite a lot of topical agents and or specifically oncology, because that wasn't reliably captured in the data set that we had. So trying to define the population, trying to define the window, and also the medicines that were included and excluded in this count for prevalence. I think also the richness of what we were trying to do, and as I alluded to earlier on, we had experts from our network from each of those countries to try and contextualise actually the data asset that we were working with, and also the healthcare system, importantly, that might be impacting on that data interpretation piece. And we used a tool that was had been previously published by some of the team, looking at how to try and think about cross-national comparisons and good practice guidance for that. So over to the results. Where we had a study population, so we had good coverage across the 6 countries. Really, in the context, we had quite comparable age for this population and gender. And then you can start to see, as you look at this table, the range of actually polypharmacy that we categorised as over 5 or 4 medicines. And that range really from, in the UK, 22% up to over 50 in 4 of the countries. So over four of the 6 countries we looked at with the data asset that we had polypharmacy defined as over 5 medicines in over half of that population. And when you get down to looking at over 10 medicines in those populations, then that was highest in Germany and lowest in the UK, but still quite a significant medicines burden in these populations being looked after in primary care through general practice. So that's the overall population. And then we also looked at these potentially inappropriate medicines, and we looked at the antipsychotics and benzos, clear evidence that there's concern around these in this population, and also the increasing use of long-term proton pump inhibitors. So we looked at that in the overall population, and the data is there and in the paper for you. Quite high variability across the different nations, which was important to then understand what we were and weren't capturing. But really, when we look at proton pump inhibitors for this population over 65, quite a large exposure to PPIs. When we move to the polypharmacy subpopulation, then this is the characteristics of that population. And we were using primary care data from the platform, from IQVIA, but we were challenged in part by actually using the extent of data that was looking at comorbidity or where there was potential for missingness in this. So these were quite high. Obviously, we feel that that's unrepresentative of what we were dealing with, but that was based on the classification that we used. But interestingly, 2 of the key comorbidities that were coming through quite strongly across the piece were respiratory and diabetes as common within this area, and might be also driven by the capture of the medicines that we were being able to look at in primary care. This chart just shows you for the kind of topmost prevalent drug classes for that polypharmacy, and probably no surprises to this audience that we were looking at the peptic treatment of peptic ulcer disease, looking at antithrombotic cardiovascular care, beta blocker areas, and other lipid lowering, so cardiovascular, and then also analgesia here at the end. So starting to understand where is the burden of that polytherapy in this population across the different countries. And then when we got to the potentially inappropriate specific medicines and we looked at them across the countries in a little bit more detail, then you can obviously see from these figures that for the PPIs, this was quite significant in all countries. Much lower for antipsychotics, but again, you need to put cautious interpretation of that, depending on how much of that was captured in the data set that we were looking at. But again, quite a high burden around the benzodiazepines and the opiates in this population. So coming to strengths and weaknesses, we were looking at this methodologically and trying to standardise processes so that we were working on a single platform and we had good country-specific understanding of the complex system, which we hope we brought through in the discussion in the paper, and that our limitations really are detailed there. And it's not about saying number and volume is high, but it's about getting, how do we get from the count that we were trying to standardise to understand what's appropriate or not appropriate polypharmacy, polytherapy going forward. So I think the implications here is that we need to think about, as we drive tools and as an international community, how we can look at routine data as a means of surveillance of the effectiveness of the different types of strategies that we're trying to engage with, both within a country and across countries, in a much more routine, light way, and not heavy lifting on the data and the monitoring side. And that we need to think about how this sits in the wider data set, looking at different subpopulations within the examination of polypharmacy. So for us, the conclusion here was, and quite stark, that we have significant burden of polytherapy in the older population, and in 4 of the 6 countries, this was really over 50%. Quite an increasing, worrying amount of potentially, and we may say that because some of that will be appropriate therapy, but potentially inappropriate medications, and the potential harm that that may do in this population. And also that the context and the intelligence of when you come to compare cross-national studies, that you have that contextualization, I think, is important, so that it's not alarmist in how you use these large cross-national study data. So I hope that's helpful, and I'm happy to answer any questions. Thank you.
Thank you, Mariam. That was wonderful, and so good to see what is actually being prescribed in different countries. I did not see a question yet in the Q&A, although I did get a question or a remark in the chat saying that some people have some difficulties putting their questions in the Q&A. So despite what our host says, feel free to put something in the chat if you want to. And I'm sure she'll scold me for it later for saying this, but if you have trouble submitting a question, just put it in the chat. Question for you, Mariam, if I may go first, Peter, or do you have a question?
Yeah, I just have a comment that I think that in this polypharmacy, the major problem is that we don't know the multiple interaction of the different drugs. So I see we have a research project ongoing with the network assessment of the vigilance database to find out new interactions, because we guess that most of these multiple interactions are just not known yet, if they have any inappropriate use and interactions. So this is a major problem I see for the polypharmacies. Only a fraction of these multiple interactions we know if we have like 7 different drugs given together.
So some of the work that we're actually working with just now, Peter, is as part of a UK medicines programme is looking at particular areas. So some of the areas we're in is anticholinergic burden, so cumulative burden there, which is in effect an interaction, and also in the acute setting, multiple accumulation around high dose and antipsychotics and the harm that comes with that. And we're coming from the perspective of how then do we build clinical decision assets that can sit within our electronic prescribing systems that add value to that clinical prescribing process, as opposed to just creating noise that then clinicians will switch off because they can't cope with the multiple interactions that are coming through some of the software that's happening just now. So I think we need much more intellectual clinical decision support in this complex area of multiple medicines and their interactions, and therefore clinical consequence of that.
And we need new data on it. So
absolutely
basic science input for this
to drive clinical decision support. Yes, absolutely.
Yes. So this is what we are working on, to find out new input data and how to dig out these potential interactions, for example.
So we did get a question from Rhea Shah, who said, did you get any sense of why the prevalence of polypharmacy is so much higher in Germany compared to the UK, despite similar age and comorbidity?
So, really good question and very difficult to answer. Our view was that some of this may be about what we're counting or not counting. So really, we think, although we're understanding with IQVIA platform that it's a representative sample of physicians and of the population, because the healthcare system is quite variable and dependent on how much is specialist therapy versus generalist therapy, may be having quite a significant impact on that. And I think for that is part of it, but we weren't able to fully unpack that, just in part because of the scale and the size of what we were trying to do as a first cut with this data, but a totally relevant question there. And I think what it does do is it at least starts the conversation. So you start to say, well, there is here, we're controlling for these things. What are we not controlling from, and what might be interesting to think about in the context of moving forward?
Yeah, thank you, Marion. I have a question for you, but maybe that's for later. But because I think we'll open the floor now to all of the participants, to all the speakers. May I ask you to turn on your camera again? Gautam, you may also do so. And maybe there are some questions. I'll first go to the Q&A box. Well, at least Rhea said that she was very thankful for your answer. Perhaps, Peter, do you have any questions? In the meantime, feel free to ask some questions for the open discussion.
Yeah, actually, anyone? Not right now. So thank you very much, first of all, and congratulations for your the most downloaded papers. I think that both with Marion and Henrika, we have some common interests, so I will just send you some papers. Maybe we could collaborate in the future, and feel free, and I encourage you to submit your papers to BJP or BJCP. So we are very much open for the best pharmacology papers, either preclinical, translational, or clinical.
I have a question for if I could start with Gautam first. Do I pronounce that correctly, Gautam? Or yes, I'm sorry?
It's absolutely right.
Okay, all right. So being in Gotham, of course, myself. So that's what I said. You know, I'm married to an immunologist, and each time when I think I understand it, something she tells me, oh no, that's completely different. There's different things, and especially if you translate from one species to another, and ultimately in humans and so on. So obviously, if you give the antibody, are there any other, what you observe, any other mechanisms outside of the CCR8 that could actually explain some of the response or lack thereof when you're in humans? And are you able to capture that or somehow incorporate that uncertainty into your translational PK/PD models? It's a very difficult question, I understand, but
Yes, I think it's a very broad question, not specific to CCR8 antibody, but in general to the translational field. And I think your question is more geared toward the PD component of PK/PD, right? With regard to PK, we understand the PK of antibodies and how to translate them, especially from a higher order species such as cyno. I think that's a little more I would say, less tricky, because everything in science can be tricky depending on the antibody. But as long as the antibodies are not having anything funky in terms of changes or the newer sort of modalities where you still see funky PK, but at least a typical antibody we can translate pretty well. With regard to PD, it comes with those challenges. And that's one of the reasons, for example, with anti-CCR8 antibody, though we had rich mouse data, we did not use that to translate the efficacy piece. We relied more on the PD from cyno and the PK from cyno. And the reason for that is, one is the difference in immunology. For example, something like the NK cell content in these efficacy models, mouse models, could be very different than the NK cell content you may eventually see in the patients, particularly in the tumor microenvironment. And since we're going after ADCC, we need NK cells to do their job, right, essentially. So that's one example. And the other example is, the other reason is we use the surrogate clone in the mouse efficacy studies because it does not cross-react, and there are some differences. While we could factor some sort of PK differences, affinity differences to sort of do the translation, the bigger challenge for us was how much we can rely on these mouse models in terms of translation. For proof of concept, yes, it is very useful, of course. But in terms of translation, the interspecies scaling could be difficult from the PD and efficacy point of view.
yeah, thanks. Very cool.
And the other reason, the other way we try to mitigate that is using dissociated tumor cells and do some in vitro assessment, because dissociated tumor cells are derived from action patient samples. So they are more reflective of what we may see in the clinic. And that's the sort of get around we try to do using a lead candidate.
Right. Very good.
I have a question to Henrika. So, do you have any idea how many drugs have been investigated, if they get to the breast milk or not? Because I think that most of the drugs are just not investigated at all, so therefore they just say that it's not applicable for pregnant and breastfeeding women, because that's the easiest way.
Yeah. I don't have a number at hand, but I would say that they have been investigated. So many of them have, at least for a few studies. So I would say the most common drugs that are used, I would say in every group there are some drugs that have been characterized. Not very many have been replicated, and many have been done years and years ago, not taking into consideration the metabolites, for example. But I would say there are in less than 100 of those studies that have studied any drug excretion into breast milk. Yeah, as far as I know.
Thank you.
I had a question like with many of you as clinical pharmacologists or pharmacologists, we got dragged into other people's research to provide some input or think about it, or maybe we actually really have to do something. So I also got involved in some of the opiates and neonates here. And one of the things that I was surprised of was that there might be epigenetic changes during continuous opiate exposure, or during opiate exposure, especially in neonates. Oh, sorry. Perhaps you might hear the New York City scenery in the background because there's a lot of sirens, etc., going off. Do you think that with the exposure that you've simulated within the neonates, that might be a problem? Because it might be at different levels from the actual analgesic effects.
Yeah, what we did was quite, I would say, the simulations go to a very extreme. So I would say that most of the cases would be our normal situation. For example, we did decrease clearance, which of course can happen, but I would say they are unlikely. Also, the volumes that the neonates would consume are rather high, especially for those first 3 days that we were studying. So yeah, I would say it's unlikely to reach toxicity, and I would say that this regimen is rather safe.
Thank you. Marion, I got one for you. That is maybe while I was listening to you, for some reason I was also thinking of the Eurovision Song Festival, and there can only be one winner. So, what country did best?
I don't know if there's a one one does best. Based on the evidence that we saw, the UK, and obviously I have an interest in it, and I'm not quite sure if it's a data issue or not still, but we seem to be quite low in the context of the prevalence of polypharmacy. And you know, my counterparts who were the clinical reps in the context of this felt that there'd been quite a focus on this as a policy, a medicines policy strategy area to try and bring in medication review as part of our health system, primary care health system. And there was various influencers in that, both in the pharmacy dimension, which professional area that I work in, but also within primary care general practice. So different frameworks driving that area of attention. And it would be, you know, we only looked at a particular window in time, but actually looking at that in trend. And that's why I think the power of the data comes for. If you can get this longitudinally over time and you can understand where your interventions are coming in for the different initiatives in different countries, you would maybe start to generate new intelligence around that. But there was a feeling that in the UK there was potentially more of a joined up focus on this polypharmacy piece, but it's maybe slightly different from the multiple specialist type access to different healthcare systems in some of the other countries. That was some of the kind of dialogue coming through.
Thank you, very interesting.
Just one comment to Marion. Do you have any collaboration with the group who creates this BEARS list of inappropriate use of drugs for the elderly?
So some of our wider community, yes, absolutely are. So there's some people within the group that are very much engaged in that and the stop-start criteria and various other tools that have been used out there from the different European communities. So yes, the answer, Peter.
I sent you a link, by the way, on the chat, Marianne. Yeah. Okay.
Okay.
There's a question for Andreas. Professor Papapetropoulos, if another review is written for 2024, or will you mention if drugs from the previous year have been withdrawn? Is the longevity of novel drugs also being considered?
Thank you for the question. There will be another review for 2024, and at least for the 2023, we decided not to include drugs that were withdrawn. So we might have to, we might revisit that.
It's a good idea. Yeah.
It's a good idea. We thought about that, but we could change what we did last year if we think.
Yes. In fact, it was really difficult when we came to this conclusion that the different years of approval really makes this job very hard. So sometimes, it takes 2 or 3 years difference for the FDA or EMA to approve a drug, for example. And and we don't know in certain years that it was disproved by the EMA, or it's just still ongoing. So it's very difficult to dig into all these data. So,
yeah, excellent. Well, I don't see any more questions in the Q&A or in the chat. I haven't got anything else written down, at least myself, other than things that would go into a further discussion, but might take way too long to answer. Peter, do you have...
Yes, thank you very much for everybody. I think that no more questions, so we can release the victims. Thank you very much for your contribution.
Thank you so much.
Thank you very much.
Yes.
Thank you.
Bye. Bye-bye.
Bye.
Thank you. Bye-bye.
Bye.